Okay, welcome to Microbiology. We're going to be talking about peptic ulcer disease and esophagitis, and this is just from a microbiology standpoint, so we're not going to be covering everything that you might learn in Path as well. Alright, so let's start with the most common one. Let's start with peptic ulcer disease. So, peptic ulcer disease, the agent that creates peptic ulcer disease, there's many causes of it, but as far as microbiology is concerned, we're worried about what? H. pylori. Okay, so Helicobacter, if you remember, Helicobacter is a gram-negative bacteria. Gram-negative is microaerophile, so it can enjoy areas of both aerobic and anaerobic conditions. Okay, and then the other thing, just remember it's positive everything, alright? So we got catalase positive, oxidase positive, urease positive, okay? So it's just positive everything. It's really easy to remember. Remember, it's spiral. It's not a spirochete, but it's motile and it's curvy. Okay, so it kind of looks like, you know, there's some curves there, and then it's got some tails coming off the back. It's kind of interesting like that. Okay, you'd recognize one on a slide, not a ground stain, but on a slide they kind of look like that, just like curved rods. Okay, so pretty easy to recognize. So let's talk about the epidemiology. So as far as epidemiology, how do these get in us? Fecal oral route. That's how they get there. So fecal, oral, and these guys, of course, like to chill in the stomach. Okay, so they want to be in the stomach. The reason they want to be in the stomach, let's talk about that. They have 3 virulence. Okay, so 3 virulence. It's really easy to remember. 3 virulence are the most common one we always talk about is urease, right? 2, it's CAG-A, and 3, it's VAC-A. Okay, so we're going to talk about each of these and how they affect the pathogenesis. Alright? Let's go over real quick what they do though. Okay, urease, what it does is it turns urea into ammonia, NH3 plus CO2. Alright, so this creates an alkaline environment for the bugs. CAG-A, this acts on actin. It also increases cytokines under the area. VAC-A, this is just the cytotoxic portion, okay? And I'll tell you why this bug needs the cytotoxic portion so much. It's actually interesting. What happens is when H. pylori gets into the stomach, it does not invade the cells of the stomach. Okay, what it does is it just chills in the mucosal layer. Okay, so it invades the mucosa. The mucosa is the very top layer, and it just stays there. Okay, what attracts it to the mucosa is urea and hemin. I mean, there's other things too, but urea and hemin are kind of your high yield terms for what attracts it there. So urea and hemin, they get it to the area, and then it starts using its virulence factor, right? So urea is broken down into NH3, making an alkaline environment. Okay, so once it makes that alkaline environment, then it's able to chill and it feels good. This is not an acidophile, okay? These bacteria are not acidophiles, they're neutrophiles. They like neutral area. They're able to withstand the acid for a little while, and then they make it an alkaline environment for them. All right. So other things that happen at the same time is that it's able to use the CAG-A to recruit pathogens, okay? or cytokines. I'm sorry, to recruit cytokines, and this increases the amount of inflammatory cells that are available. So once we have inflammation and things like that, then it creates several other problems, and all of this is kind of destroying the mucosal layer. Now, what VAC-A is for is VAC-A is cytotoxic. Okay, so VAC-A gets in and destroys even the layers underneath as well. All right, the submucosa, and it gets into the epithelium and the cells, especially can affect like the parietal cells and all that in the long term. Okay, so VAC-A is used cytotoxically. All this creates an area where basically the VAC-A, what it does is it causes a decrease in cellular integrity. I guess that's one way to say it, okay? Integrity. When you have decreased cellular integrity plus acid destroying all the areas, plus the acid destroying all the areas, then we get ulcers, right? These ulcers. Okay. So this is the pathogenesis, this is how we get our peptic ulcers, and this is the way that those three important virulence factors are used in that process, all right? So some symptoms that let's talk about the outcomes first. So the outcomes that we want to talk about are, there are three outcomes that we want to talk about, okay? So the first outcome that is common with this, I hope you guys can read this crap. Okay, so the first outcome that's common with this is that, okay, so the first outcome that's common with this is we get ulcers, right? So we've already talked about how we get ulcers and that kind of pathogenesis. Some uncommon now outcomes are that we can get a lymphoma, okay? So we can get a malt. What happens is once the cytokines are released and the inflammation and stuff like that, these B cells, they're brought to this area and they're brought very rapidly. And so then we start to get this antigen process that's occurring. Kind of move that. So we get antigenic stimulation at that point. So antigenic stimulation. And normally we get that antigenic stimulation with B cells. It just happens in the germinal center. So nothing can get out of control. But once it's out here, it starts to get out of control. We get antigenic stimulation. It gets out of control and it creates this malt. Okay. The third one is an obvious, after years and years and years, CAG-A is responsible for an adenocarcinoma. And it's inside the stomach, right? So this is the only bacteria that I know of that actually causes cancer, okay? And the way it's causing cancer is through CAG-A. So we know of viruses that cause cancer, we know of fungus that causes cancer. Those are all high yield. Anything causing cancer is going to be high yield, all right? So this is a bacteria that's causing cancer, and it's a very common cause of an adenocarcinoma. Just as a matter of it taking a long time and having refractory peptic ulcers, and then not having that taken care of. So we need to get that taken care of. So the diagnosis, it's best just to use, well, it's not best, but you can use the urease breath test. Okay, so urease breath test is very common. You can just check serology, and that's probably your gold standard is to check serology. The easiest one is probably urease breath test, and then your gold standard is to check serology. As far as treatment's concerned, that you need to know about, it's called triple therapy. Okay, so this is high yield because if we treat this, then it really. Anyway, if we treat this, then your chances of getting cancer are going to be big time decreased, and so we treat it. The problem is your chances of. Oftentimes, people say that there's an inverse relationship between treating peptic ulcer disease and the symptoms and signs of GERD. So when we treat peptic ulcer disease, for some reason, somehow that has an effect on gastroesophageal reflux. So people who have treated peptic ulcers and have had like a history of GERD, their GERD seems to increase. Anyway, so treatment, we first do 14 days of triple therapy. And the 14-day triple therapy is a PPI plus amoxicillin plus clarithromycin. Okay? Or you can give metronidazole. All right, so now that's for the first 14 days. And then 10 days after that, you do this dual therapy. So you do proton pump inhibitors twice a day, plus, let's go in alphabetical order, amoxicillin. Okay? And that's for days 1 through 5. And then in days 6 through 10, you do your proton pump inhibitors plus your clarithromycin, or you can give metronidazole, okay? So alphabetical order, as far as that's high yield, I think, as far as what you need to know for your step and for a comprehensive exam or final exams if you have them. That's how we treat it, okay? That's high yield. And that's pretty much it. Most of you know the signs and symptoms. You can get melena, you can get vomiting, you can get pain upon eating, or it can, if the ulcers tend to be in the duodenum, then pain decreases. The reason the pain increases in the gastric ulcers is because you increase the acidity as you eat, and so it causes the gastric ulcers to be affected a little bit more. All right. So let's talk about esophagitis really quick. In fact, not enough time. Okay, so esophagitis, the main causes of esophagitis are Candida and CMV. So Candida, okay, so the main causes of esophagitis are Candida, Candida albicans. And I remember Candida albicans because it's kind of the rule of twos, everything's in two, okay? So the first two is that, first of all, it can be part of your normal flora. And when it's part of the normal flora, it's just known as a yeast, alright? But once it starts invading and things like that, then it becomes hyphae and pseudohyphae, okay? And that's when it's causing problems for us. The other rule of two is that this affects two types of people. One, immunocompromised, and two, it affects those post-antibiotic, okay? So this is post-antibiotic therapy. Okay, so post-antibiotic therapy. Let's see. The rule of two, oh yeah, so it can affect two parts of the body, right? I mean, one, it can cause oral thrush, and two, it can cause esophagitis. And oftentimes, what you'll see basically with this patient is odynophagia, the complaint of odynophagia, especially if it's esophagitis Candida, because you're not going to be able to see it, right, unless you send a scope down there. So they'll complain of odynophagia. And then when we want to diagnose this, this can actually be seen on a bacterial auger, and they just look like white tiny little spots on a bacterial auger. And then the other way that you do this is with a KOH, right? So that's the most common one, KOH, one that most people know about. And that's it, CMV. CMV can also cause it. Just remember the little owl eyes, right? You got the owl eyes for CMV, and that's pretty much it. If you see a case of esophagitis, it's going to be one of these two, as far as microbiology is concerned, and so that's what you need to worry about, okay?